episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom. This is the fifth in a very important series featuring the Myeloma Crowd Research Initiative. For the first time, patients, including you, are teaming up with myeloma researchers to find and fund the ideas in myeloma that could have the greatest impact for the next generation of myeloma therapies. We decided to go after high-risk myeloma because these patients have pretty dismal outcomes and few working therapies. Ultimately, if we become relapsed and refractory to current drugs out there, we also become high risk. And we are thinking that what works in high risk will help low or standard risk patients as well. We asked researchers around the world to submit their proposals, and we received back 36 high-quality letters of intent. Those were then scored by our scientific advisory board, and 10 proposals were selected. We're now holding Myeloma Crowd radio shows so that you can be involved. We would like you to understand the proposals, so please listen in, ask questions, which you'll be allowed to do at the end of the program, read the transcript after the show is posted, and share it with your friends and family. This is very critical work being done in multiple myeloma. After the proposals are submitted, the Scientific Advisory Board and Myeloma Patient Advisory Board will together decide on a limited number to fund through patient-driven campaigns. Again, we will need your help to get the word out and share the really amazing work that's being done. Now, here's one way you can share today. We have a campaign open at mcri.myelomacrowd.org. We would love for you to register and start building a team of family and friends who can help support you to fund this effort. We will be posting our final selected projects in the coming months. Now, we are delighted today to have with us Dr. Ivan Borrello of Johns Hopkins. Welcome, Dr. Borrello.
Hello, everybody.
Okay, let me introduce you before we begin. Dr. Ivan Borrello is Associate Professor of Oncology, Associate Professor of Cellular and Molecular Medicine for the Graduate Program, and Director of the Cellular Therapeutic Center at Johns Hopkins School of Medicine. Dr. Borrello and his team of researchers have focused on the development of tumor immunotherapy for blood cancers that use cancer vaccines as well as patients' own immune system to fight their cancer. The particular treatments developed in Dr. Borrello's laboratory are known as adaptive T-cell therapy with MILS, which we will learn about today, and have broken new ground in the fight against diseases such as multiple myeloma. Dr. Borrello is the widely published author of many peer-reviewed articles and book chapters, a member of several national oncology organizations and professional societies. Dr. Borrello is asked to speak regularly at symposia around the world. He's received many honors and awards, including the American Society for Clinical Oncology Scholarship Award, the Johns Hopkins University Clinician Scientist Award, the Kimmel Scholar Award, and the Leukemia and Lymphoma Society of America Clinical Translational Scholar Award. So, Dr. Borrello, thank you so much for joining us today.
Thank you.
I would like to add one more individual on, Gary Peterson. He is also on our Myeloma Crowd Research Initiative Patient Advisory Board. Welcome, Gary.
Well, thank you very much. Glad to be here.
So, Dr. Borrello, if you would like to start by just describing describing your proposal and maybe helping us understand what are MILS. A lot of us are not familiar with that terminology.
Sure. So the proposal, as Jenny alluded to, is focusing to target high-risk myeloma with this approach that has been developed in my lab using MILS. MILS stands for marrow infiltrating lymphocytes. These are immune cells, lymphocytes being immune cells, that reside in the bone marrow. And as I'm sure all of you know, myeloma is primarily a disease that is limited to the bone marrow. And so if one thinks about how the immune system recognizes whatever it needs to target, and specifically in this case myeloma cells, it needs to target it by having receptors on the surface of the lymphocytes that recognize the proteins of the tumor, and they need to come in close contact with those tumors. So it made sense that the place in the body in which you would find the greatest amount of these tumor-specific T cells would be in the bone marrow. So several years ago, we actually did experiments where we took blood and bone marrow from patients, and we activated these cells with beads in the laboratory and showed that upon activation, there was no increase in tumor specificity or tumor recognition of the cells that were derived from the blood whereas in contrast, the bone marrow cells, or the mills from the patients, had roughly a 100-fold increase in tumor specificity. And this has subsequently led to a series of clinical trials, including the one that we are currently conducting, specifically targeting high-risk myeloma.
Okay, and can you expand on that a little bit? And I know, Gary, you had some questions about just the beginnings of describing mills. Do you want to ask that question right now?
I was wondering, for one thing, if mills are the same thing as CARs. We've heard, in this whole immune therapy, this universe now of immune therapy about CAR, and CAR T cells, and how, are the mills, is it the same thing, or what differentiates, a CAR from a mill? And if you could expand on that, just so we're aware, is it the same thing, or is it different in some way?
Sure. So CAR stands for chimeric antigen receptor. Basically, it is, for the most part, a virus that has been modified to have two aspects to it. The part that sticks outside of the cell is generally an antibody that recognizes a certain protein, and the part that's inside of the cell of this CAR is the signal transduction, the mechanism that actually activates the T cell. So in general, it's an antibody on the outside and T cell mechanisms on the inside. And this virus that has this construct is then put into a T cell. So those are what are called CAR T cells. Up until now, all CAR T cell work has been done using peripheral blood cells that are obtained by sticking a needle into somebody's vein and taking out the T cells or the lymphocytes. Our approach does not involve, at this point, modifying the T cells with any kind of a virus. What we're doing is taking a different source of T cells. Specifically, instead of using the blood, we're using the bone marrow. And I think one of the major differences is, as I mentioned earlier, that the blood cells intrinsically have very, very little tumor specificity, whereas the mills in general have a heightened amount of tumor specificity. And so what we are hoping to do is to use a cell that can recognize potentially hundreds of proteins that are present on the surface of myeloma as a source of T-cell therapy, as opposed to a cell that intrinsically recognizes zero or very few proteins that are present on the surface of a T-cell, and after this gene modification only recognizes one. Now, as you mentioned, CARs have achieved a significant amount of interest because, specifically with regard to the CARs that target CD19, which is a protein that's present on a lot of B-cell malignancies such as ALL, or acute lymphoblastic leukemia, CLL, chronic lymphocytic leukemia, diffuse large cell lymphoma, follicular lymphomas, and some will argue even myeloma. It's only one protein, and they have seen very dramatic results in pediatric leukemia, pediatric ALL, but have also seen that when the patients relapse that have been treated with CAR T cells that are CD19 targeting, that oftentimes those patients actually have a leukemia that is lacking the CD19. In other words, they have what is called technically antigen escape variants. So the parental tumor that expressed this protein, CD19, has been effectively killed by the T cells, and now the clones that have come up are clones that do not express this, which is not all that dissimilar in what people see when they think about antibiotic resistance. And this is a limitation when you're going after one or two proteins. So what we're hoping is that when you're targeting hundreds of proteins, that the likelihood of such antigen escape variants are potentially significantly less. And so, sort of summarizing, the differences between CARs and mills is that the CAR itself is a virus that changes the proteins or changes the recognition of the T cell. Mills are a different source of T cells, which could potentially be used together with CARs, but in the current formulation are used in the absence of CARs.
Is there, I guess the next question for me then is if these mills, like a car has to, I believe, be sensitized, right, so that it goes after the correct myeloma cell, and so you did something, and I can't remember. You energized it, or you did something different to it. It's been pepped up in some way, and I don't know what that means. What does that mean? Because it relates to another question is why if we have these cells already in our system, why don't we just pull some out like they do with T cells and just multiply them and put them back in and let your own MERTs do the MERTing?
Mills?
Right.
Or mills.
The mills, yeah. That's okay, I understood.
Do the MERTing. Or Bill's version, the milling.
The mills will do the milling, yes. So
exactly.
You ask very important questions. So basically...
I do that when I lose my notes. I couldn't find my notes. So. My other questions weren't nearly as good, but this is coming off the cuff.
That's okay.
Sorry about that, Dr. Borrello.
No problem. So basically, all adoptive T cell therapy that is currently being used is having something done to the cells out of the body. And the CAR technology, as well as the technology that we're currently using, involves somehow turning these cells on. And the reason this has to be done is twofold. One is that tumors intrinsically have the ability to poison the immune system. And that is one of the major reasons why immune therapy does not work in a patient with advanced cancer, because de facto the immune system has poisoned the patient's, the tumor has poisoned the patient's immune system to be able to function effectively. What we have seen over the past few years is that we are beginning now to figure out how we can reverse that process. So the analogy that I like to give is that the immune system is drunk, and we have to do something to sober it up. And this can be done in terms of adoptive T cell therapy by taking these T cells out. And in the case of what we're doing, which is what a lot of CAR technology is also doing, is we add beads to these T cells that can stimulate the T cells. And so that achieves two purposes. One is that it wakes them up. And the second thing that it does is that it allows the cells to effectively expand. So we can get about 100-fold expansion of these T cells. And not only do we expand them in numbers, but when we look at them, they now all of a sudden are T cells that can actively recognize and kill the tumor that they are specifically targeting. The same process is done whether you're using CARs or mills.
Can I ask a follow-up question on that?
Sure.
And I know the immune system of myeloma patients are compromised and are not working properly, otherwise they'd be able to kill the myeloma. So are the T cells that we typically have when we have myeloma, are they mutated? Or are they just not doing their job? Are they suppressed? What's happening with the normal T cells?
That's also very good.
What should be normal T cells?
Right. So it's been shown, especially if you look at a disease like myeloma, which from a scientific standpoint is a very interesting disease to study, because as I'm sure everybody knows, that there's a pre-myeloma condition called MGUS, or monoclonal gammopathy of undetermined significance. Then there's smoldering myeloma, and then there's active myeloma. Right. And even within active myeloma, there's early diagnosed, newly diagnosed, and then there's relapsed myeloma. And I think, as Jenny alluded to at the introduction of the talk, as patients relapse, they acquire more genetic hits that de facto transform the disease into what would otherwise be a more aggressive disease. And it's been shown that when you map this out from MGUS to smoldering to active to relapsed myeloma, that the patient's immune system becomes less equipped at fighting the cancer. So in general, there's this concept that has been demonstrated in mouse models called immune surveillance. And the concept is that our immune systems, in general, are capable of recognizing and killing tumors when they're present at a few cell levels, so at a 1, 2, maybe 10 or 20 cells. When these cancers arise, our immune system can most often effectively recognize it and eradicate it. And because of that, we actually see a lot less cancers than we would have. And an example of this is that if you look at patients that are immunocompromised, so for example, patients that have AIDS or patients that have undergone a solid organ transplant that are on chronic immunosuppression, such as cyclosporin or tacrolimus or other drugs like that, their likelihood of developing secondary malignancies is much higher than in somebody that has an intact immune system. So that really proves the point that we do have, our bodies normally have this process of immune surveillance, of having our immune system sort of go around our bodies and attacking these few cell cancers that are forming. And it's when these escapes occur that we then develop clinically detectable cancer. So how does that occur? Well, that can occur through a variety of reasons. One aspect of it is that the cancer is just growing much quicker than the immune system is capable of recognizing, and therefore you get clinical outgrowth. A second aspect of that is that the cancer itself is capable of effectively poisoning the immune system to dramatically reduce the ability of doing immune surveillance. And then another aspect is that the cancer itself can mutate in a way that it's capable of effectively evading the immune system. And so there are multiple mechanisms that really play a role. But what has come out and is becoming more and more clear is that a lot of this is an interplay of the tumor with its microenvironment, of which the immune system plays a significant role.
Do you want to talk about that for a minute? Because I know we've had shows in the past that talked about the importance of the bone marrow microenvironment, and the things that are happening in there will either shut down the growth or expand the growth. Do you want to address that?
Sure. So I think the tumor microenvironment and the role the tumor microenvironment plays, is increasingly being recognized probably as being as important, if not more important, to really understanding the biology of the tumor itself. There have been, and an example of that, especially in myeloma, has been work done by several groups where they have actually shown that one of the things that allows a myeloma cell to survive, its ability to attach itself to the stroma, which is basically the infrastructure or the scaffolding, if you want, of the bone marrow. And the mere ability of a plasma cell to attach to this scaffolding intrinsically confers chemoresistance. So in experiments that were done, if you take a bone marrow, if you take a plasma cell and you have it just floating around, and they are liquid cells, so they can't float around, and you can kill it, let's say, with 10 milligrams of drug X. If you take that plasma cell and attach it to the bone marrow stroma, the scaffolding, now 10 milligrams of that drug X are no longer capable of killing the tumor. You now need to go up to 100 milligrams. And, these experiments have been shown over and over again. And so one aspect of it are these cell adhesion molecules that are capable of conferring chemoresistance. Other aspects of it are the role that the immune microenvironment plays. And so the T cells, we've talked about how to use them to fight the cancer, but we've also published work showing that what happens within the tumor microenvironment is almost a triangulation, that the plasma cell itself can produce certain proteins that ultimately cause the T cells to produce other proteins that are basically responsible for the bone destruction that is not uncommon in multiple myeloma, the thing that ultimately causes lytic bone disease. And that, in fact, a significant amount of the lytic bone disease that we see in myeloma is in large part driven not by the tumor itself, but by the immune system, by the bad immune response that the tumor actually elicits. And so being able to block that can be critical in terms of preventing preventing bone disease. There are other cells in the bone marrow that have been shown, and these are also immune cells called MDSCs, or myeloid-derived suppressor cells. And these cells have been shown to be able to transform themselves within the myeloma microenvironment into osteoclasts, which are cells that actively destroy bone. And these MDSCs are also cells that can confer chemoresistance to the plasma cells themselves. So these are all things that when you take the totality of the environment in which the myeloma cell is living, I think allows for an explanation for some of the discrepancy as to why a lot of clinical papers that basically just take plasma cells and put them in a tissue culture dish and show how drug X is so effective, that when you then go into in vivo systems, whether it's mouse models or human clinical trials, tend to oftentimes give only a fraction of the benefits that we're seeing with a lot of these pure in vitro models.
And that would explain why some patients have extreme bone damage and some patients don't have that much bone damage.
Well, in part. So we published a study where we actually looked at. So we looked just by X-rays at how much bone disease was present in patients. So and so we graded it 0 through 4, with 0 being nothing and 4 being, a ton of bone disease. And then we actually looked and said, how much myeloma did these patients have, and were there differences? And we showed that there were absolutely no differences in the amount of tumor in patients with 0 bone disease versus 4 plus bone disease. But when we looked at the immune response of these bad cells, we showed that one specific protein, and in our case it was this protein called interleukin 17 or IL-17, that together with a whole bunch of other proteins that go along in that pathway was highly predictive of the development of bone disease in these patients. And so one of the interesting things, for example, of the mills is that as we activate these mills, we actually completely shut down this IL-17 pathway and turn on another pathway, which is called the gamma interferon pathway. And that gamma interferon is very effective in reducing or in poisoning osteoclast formation, osteoclasts being the cells that induce bone disease.
Okay, well, there's a lot happening in what you're trying to do. Maybe it would be better to take a step back. I know that myeloma is considered a very heterogeneous, there's a lot of heterogeneity, I guess, which means, not all patients can have multiple types of myeloma in their cells. And what I hear you saying is that as opposed to like a CAR T cell where they're attacking one protein, this approach would be more able to target maybe hundreds of different types of proteins. Can you go into a little more detail about how that works? And then I think we'll go through the process of how you're using high-dose chemo with the mills.
So in terms of making a therapeutic mills product, as I mentioned, we really started off in a very simplistic manner, trying to take advantage of the natural biology, and the idea being that these T cells that reside in the bone marrow are intrinsically myeloma specific, but they're not effective. And so what we showed is that in order to make a good product, we actually need to be able to grow these cells in the laboratory in the presence of tumor, that the presence of tumor, as these cells are being activated and expanded, can actually drive the tumor specificity of these mills towards greater myeloma specificity. And in terms of the exact proteins that they're targeting, we don't know. We're beginning to look at these, but the idea is that they're going to be targeting anything that's present on the surface of the myeloma cells. So if you have a patient with high-risk myeloma, presumably the proteins that are being expressed on the surface of his or her tumor are going to be proteins associated with the high-risk myeloma. And in contrast, somebody with a low-risk myeloma, for example, will have a different set of proteins. And so I think when one looks at the entire repertoire of immune proteins that can be found in myeloma cells, I think it's probably fair to say that maybe 60 to 80% of them would be what we would call common common shared antigens or proteins that are present on all the patients. And then each individual will have his or her unique antigens or proteins that will define their disease and set his or her disease apart from everybody else's. And by taking an autologous approach or a patient-specific approach, hopefully as many of these different antigens or proteins will be recognized and will be primed, and so we will therefore be able to develop a Mills product that can recognize as many of them as possible through this process of T-cell expansion. Now, in terms of why we would ultimately give these in the setting of a transplant, that really is based on another biological point. I think most of you are aware of the fact that if you chop out somebody's liver, it will grow back to its normal size. I mean, this was described in Greek mythology and certainly has been proven in a variety of different situations. And basically the concept there is that there is a predefined size that our body has for a liver. It turns out that that same concept also exists when you think about lymphocytes or the immune cells, that there is a defined range of lymphocytes that are present in our body. And so if for whatever reason too many of them go in, then our body stops producing lymphocytes to bring it down into the normal range. And in contrast, if we don't have any lymphocytes, our body produces a whole bunch of proteins that allows us to bring us up to the normal range. So one of the things that I think is unique to a lot of hematologic malignancies, such as myeloma, that really allows us to superimpose immunotherapeutic protocols very nicely, is the fact that bone marrow or stem cell transplantation is a therapy that is widely used in a variety of these different diseases, including myeloma. And so, as I'm sure everybody knows, with a stem cell transplant, patients get high doses of chemotherapy that completely wipes out their bone marrow. Their blood counts basically fall down to zero. Now, and then, most people are focused on how long it takes for the neutrophils to recover, because those are the cells that ultimately allow them to fight bacterial infections and to get them out of the hospital. But it turns out that in addition to the neutrophils falling down to zero, the lymphocytes also go down to zero. And that becomes a situation in which, as an immunotherapist, we can take advantage of that, because if we put in lymphocytes, such as Mills or even CAR T cells, into a setting in which basically the overall number is zero, there are going to be so many proteins in circulation that are sending signals to increase the number of lymphocytes that we can allow nature to further expand the product that we have just put in. So basically, we are expanding the product 2 times. We're expanding them ex vivo in the lab as we're giving these beads and allowing these cells to grow. And then we can put them into the patient and allow them to expand even more by virtue of natural processes that are associated with a patient that's undergoing a stem cell transplant. And so right now, the trials that we have going on focuses on integrating this adoptive T-cell therapy with Mills in the context of a transplant, but I think it will easily be possible in the future to do this with a therapy that will wipe out the lymphocytes, but not necessarily wipe out all the blood cells. So in other words, we could possibly do this giving a reasonably high dose of chemotherapy, but not necessarily having patients undergo a stem cell transplant or a bone marrow transplant.
But for now, you're using transplant to get there, right? This would be in the future?
Yes, correct.
Okay, well, I think patients everywhere would love different approaches. Using immunotherapies and a combination of what's out there. So let me go back and ask you about the individualized nature of this. So in your process, you're taking some bone marrow T cells out, and then you're engineering them on an individual basis, and then you're giving high-dose chemotherapy for the transplant, and then you're giving them back to the patient. So this is all particular to the individual patient, or maybe you can clarify.
Yeah, no, this is a patient-specific product. So patient X comes in, gets his bone marrow done to collect the Mills. the cells are expanded, then the patient starts a transplant, and then days 3 and 4 after the transplant, they get their own cells back. So everybody has to get his or her own cells taken out and then gets his or her own cells put back in.
Okay. Well, that's amazing. And for the bone marrow collection, what's involved in that?
So it's a bedside collection. We basically have to collect 200 mLs of bone marrow, which sounds like a lot, and it is a lot. But we do this by giving the patients conscious sedation, and so they're awake. It's sort of like what patients get when they get a colonoscopy. They're in a twilight zone. Generally, the way we do this is I go in together with another individual, and where each one of us is on one side of the patient, and so we go into the bone marrow on both sides, and we collect the 200 mLs of bone marrow, which the time in the bone marrow to collect this volume of bone marrow is about 10 to 15 minutes. But the whole procedure to get set up, to get the drugs, to get monitored, is about an hour.
Mm-hmm.
But it's outpatient.
Okay. Okay, and then they go through the collection process. And how many days past the transplant do you give these cells back?
So we're giving them back on days +3 and +4. So that's days 3 and 4 days after the transplant.
And then for how long, when they go back into the patient and they expand, for how long are they active? I know in some of the CAR T-cell therapies they were saying they could be present for up to, a year or more. Is that
right.
the same
Yeah.
with how these work?
So I can't tell you for sure. And the reason why they can tell you that with CAR T-cells is because the T-cells are gene modified. So they can pull the cells out and actually look for the gene and say, okay, now out of these 1,000 cells, 50 of them are the CARs. We are basically taking cells out, just expanding them and putting them back in, and we're not gene marking them in any way. But I can tell you that, and our first paper is going to be coming out at the end of May, where we looked at the tumor specificity of these mills, and we were able to show that in the first trial that we did, that the tumor specificity of these cells peaked at 6 months, but was still detectable at 1 year out from transplant, and that the overall clinical benefit of these cells correlated with, the overall clinical benefit from the whole trial, which is transplant plus mills, correlated with the degree of immune recognition that these mills had. So in other words, the greater the myeloma-specific immunity that was generated by the mills, the higher the likelihood was that these patients achieved a complete remission. So again, we could still detect some of that at 1 year, but I couldn't tell you for sure whether those were the cells that we put in or if those were also cells that were being generated de novo following the transplant of the patient.
Well, what I love about this is it's truly personalized medicine, where you're targeting exactly what's present in that particular patient. So you don't have to worry about maybe, missing cells that don't have a certain target on them, and those are the cells that now grow. You're trying to attack everything at the same time.
Correct. That's exactly right. Yep.
Doctor, along that line, these mills, they are not modified in any way, because in your presentation you mentioned that they're activated.
Right.
And you actually say they're A mills, meaning that it seems like they're somehow different than the mills that you have in your system. So I was wondering, so they're really not activated, they're just expanded. Is that correct?
Well, activation and expansion, that's sort of, two different words that describe the same process. But they're not modified in the sense that we are not sticking any proteins into the cells. If you look at the cell, if you were to look at the DNA of the cell before and after we activate these cells, they're the same. The only difference is that they've undergone this expansion with these beads that has resulted in turning them on. Okay,
so there's no, what we heard about on CAR T-cells, like on the CD19, for example, is that there was some on-target and then some unfortunate off-target
Right.
implications, and these off-target implications almost killed some of the patients.
Right.
And that was
so actually,
because you don't have that issue here. Is that what
correct?
I'm hearing?
Right. So you raise a very interesting point, and one that I want to elaborate on, if I may. So the CAR T cells, at least the CD19 ones that have been used in leukemia, have been associated with very dramatic reductions in tumor burden, within weeks. I mean, they have some very nice data showing that basically the tumors can disappear. But what that's also associated with is this process called a cytokine release syndrome, which is making patients extremely sick. They're ending up in the ICU, and on a significant number of drugs, and unfortunately, in a few cases, patients have even died from the therapy itself. And one can argue, or not one argue, I mean, the fact is that this is because these T cells are hyperactivated and they're doing what they're supposed to be doing. They're just doing it too well. But I think, one of the limitations, therefore, of CAR T cells in the current formulation is that this is a therapy that is really limited to people that have very few options because the morbidity of this is so high and mortality is so high. What we're seeing with our mills is that these patients are getting they're getting some fevers, they're getting diarrhea, they're getting skin rashes, which are the kinds of things that they're seeing with the CAR T cells. But for the most part, it's a very mild form of it, and it has been self-limiting in every single situation. In other words, we have not had to treat anybody for any of these symptoms that have received mills. And so I think in the current formulation of the mills, we can certainly use this as upfront therapy. And in fact, the trial that's currently ongoing and being funded by the Leukemia Society is one in which we are giving these cells to patients that are getting an autologous transplant with high-risk disease in first remission. So a patient is being diagnosed, getting their 4 to 8 months or whatever it is of chemotherapy, and going to transplant with these mills.
Now you're saying they're doing that. Is it being done right now? I thought everything previously has been done in vitro.
No. No. So we have completed 2 trials at Hopkins that were not specifically targeting high-risk patients. We were just targeting anybody that was potentially eligible. But now we currently have a trial open. That is a trial. It's a randomized trial for patients with high-risk myeloma. If they meet those criteria, they are getting their mills harvested and they're being randomized in a 2-to-1 manner to either getting mills with the transplant or not. But the patients that are on the no mills arm are eligible to get the mills at the time of relapse. And this trial is going to be open in the next few months also at Moffitt in Tampa, Florida, as well as the Mayo Clinic Jacksonville, also in Florida. So there will be 3 sites that will be involved in this trial. And so the goal is to treat 90 patients and to see, whether the effects that we've seen so far hold up, in a randomized trial like this.
And in the randomized trial, when they can get the mills at a later time at relapse, do they do that with a transplant or by themselves?
No. So that's a very good question. So getting to this concept that I mentioned earlier about having to get rid of the lymphocytes, what we're doing for the patients that have relapsed is that we're just giving them a sort of an intermediate dose of Cytoxan, which is chemotherapy. And what that does is that causes a significant reduction in the lymphocytes. We call that lymphoablation. And then that's being followed by the infusion of the mills. So that is a non-transplant setting. And so, I think from a patient perspective, the appeal of a trial like this is that everybody's getting the mills. They're just not all getting it at the same time. So it allows us as researchers to really answer the question of what the therapeutic efficacy is of these cells. But it also allows us to answer another question, and that is, do we really need a transplant? And can we get by with just giving a dose of chemotherapy with the mills, in the absence of transplant?
Mm-hmm. Okay, I'm very curious. What led you to study this in the first place, or how did you develop this work? Yeah,
so that's also interesting. So I've had a long-standing interest in immunotherapy. Starting off back in 1997 is when I sort of started working in this field. And And we did a few trials, and one of them was a trial using the beads that we're currently using to activate the T cells, but using them by expanding peripheral blood lymphocytes. And this was done in collaboration with a company that now no longer exists. But the idea was that the patients were getting their lymphocytes collected. This product was being shipped off where the cells were being expanded in a way using the same technology that we're using currently, and then it was being shipped back. And what I saw was that this was a very effective way of increasing lymphocyte numbers, but it lacked tumor specificity. These cells didn't target anything. And so, so we started thinking there is a lot of evidence in the solid tumor literature that TILs exist, or tumor-infiltrating lymphocytes. And it's been shown, for example, in melanoma, and colon cancer, and ovarian cancer, and breast cancer, that if a patient has a tumor that has lymphocytes infiltrating the tumor, their overall outcome is better than if they have a tumor without lymphocytes, really, I think, underscoring the potent anti-tumor effect that the immune system can deliver. Furthermore, there is work being done at the National Cancer Institute where they take patients with metastatic melanoma, the skin cancer, and they take out these TILs and they grow them up. And so we hypothesize that if solid tumor have TILs that are intrinsically tumor specific, maybe patients with blood cancer, such as myeloma, might have MILs, which is why we coined this term MILs, or T cells that are infiltrating the tumor that may be tumor specific, or in this case, the bone marrow. So that was the genesis of what led us to to these initial experiments, and basically we started those experiments in 2004 or something like that, and here we are. Roughly 10 years later, now we're in our third clinical trial, and we still have a lot of work to move forward. I mean, there's still things that need to be improved upon, but I think the biology behind this is very strong. And with each trial and with each experiment, where I think we're making better products and are understanding better and better, what we can do to turn these into better cells.
Mm-hmm. And because you've already done research on this, and you mentioned that it's been done in other cancers, but specifically for myeloma, have you seen effects or changes to the bone marrow microenvironment after doing this?
Yes. So we've seen in the patients that they have. So patients getting transplanted that get the MILs have a much quicker immune reconstitution in their bone marrow than patients that don't. We're seeing that just recovering from transplant, there are much fewer patients don't have the kinds of infections that are normally associated with transplant as patients that aren't getting MILs, and we've seen more of this tumor specificity. So we've seen patients that have had clearance of the tumor. The interesting thing is, oftentimes what we're seeing, especially now in this third trial, this current trial of high risk, is that we will see a small increase in the M spike of these patients that will then be followed subsequently by a nice decrease. One of the things that we're really focusing on is to try to come up with strategies, and I think we might have it with this current trial, of allowing durability of the response. In other words, we want to make sure that not only can these patients go into remission, or a complete remission hopefully, but that they can stay in it for an extended period of time.
Well, along that line, if you in these trials, what are of the people who you had previously that weren't high risk, just normal myeloma patients? What were the results, of that complete response, kind of thing? Or better yet, did you use minimal residual disease measures?
So in our first trial, which is really the only trial that I can talk about because that's the only one we've analyzed so far, we specifically excluded patients that had achieved a complete remission going into the trial. So anybody that wasn't a complete remission was not eligible for the trial. And if one looks at overall outcomes of patients with myeloma that get transplanted, the best predictor of a complete remission post-transplant is being in a complete remission pre-transplant. And so, in a way, we were sort of skewing the data, away from that. And so what we saw is that we got roughly somewhere, I don't remember the numbers exactly, but I think it was between 35 and 40% complete remission rate from the patients in that trial. And what we didn't see, and what was sort of somewhat disappointing from that first trial, so that I think that complete remission rate was actually higher than we would have expected. But what we didn't see was durability of the response in that first trial. And so we subsequently modified the second trial, which was a trial that was randomized between getting a vaccine in addition to the mills versus not getting the vaccine. And in that trial, we also gave roughly 10-fold more T cells. And in that trial, we saw a higher complete response rate and a longer duration of remission. But as I said, I can't tell you the details because we haven't analyzed it yet.
Were these all newly diagnosed patients?
No, they weren't. So the only criterion for this trial was that the patients had to have never had a prior transplant. So in the first trial, I think about 60% of the patients were newly diagnosed, but then 40% weren't. And the median number of prior therapies was around 3. So there were some patients that had 6 prior therapies going into the transplant. In our second trial, we had the median number of prior therapies was lower because we also took patients who were in a complete remission.
So do you have any overall survival data or anything like that for?
Well, we do from the first trial. Well, from the first trial we do, and the median overall survival data I think is in the order. Actually, I don't know for sure, so I don't want to say something that ends up being wrong. But it's going to be coming out in a month, and I don't have access to the data right now, so I don't remember what it is. In the current trials that we have, but I will tell you that in the first trial we had a significant number of patients that relapsed within the first year of transplant. In our current high-risk trial, which is technically a higher-risk patient population, we have now transplanted about 25 patients, and taking both patients that got mills as well as patients that didn't get mills, we've only had, out of these 25, we've only had 3 relapses, and the median time out is now about a year and a half. And so we're seeing overall a much better clinical outcome, at least from this very preliminary overview of what's going on compared to what we did in the other trials. And this is actually almost historically approaching, I think, what would be something that would be better than would be expected considering the high-risk patient population that we're actually trying to treat.
Well, let's talk about that for a little bit. So this is basically your third clinical trial, correct?
Yes.
With this, and it's specifically for high-risk patients. So which high-risk patients are you looking for this study? Right.
So currently, the criteria for high risk are primarily based on the classic ones, which is FISH. So it's the 1Q amplification, 1P deletion, 414, 1416, 17P, as well as an LDH greater than 300, and also potentially patients that have relapsed from their initial induction therapy within 12 months of diagnosis. And then what we're doing is at the time of the bone marrow, we are also sending the bone marrow off for gene expression profiling using the signal genetics test, the MyPRS, and we're randomizing patients based on whether they have high risk per the MyPRS. So technically everybody has high risk, so you can either be high-low if your gene expression profiling is low, or you'd be high-high if your gene expression profiling is high. And so patients are being randomized so that we will have an equal representation of these high-risk patients in both groups. Now, if somebody comes in with a gene expression profiling that's high, they would automatically be eligible regardless of what their FISH shows. So, for example, I have a patient that has good risk fish, they have an 11-14 translocation, but they have high risk disease based on the MyPRS, and so that patient is eligible for the trial as well.
Okay. And how about other patients who have, this is not just for newly diagnosed patients, right? Or is it?
No, it's not.
No, okay.
No, it's not. As long as they have never had a transplant.
Okay, so if they have had a transplant, they cannot participate?
Correct.
Okay. Okay, and how about patients who you don't look at the M spike as far as your
nope.
criteria, like they could be non-secretory or something?
Well, they have to have something that's measurable. So they might not have an M spike, but if they have, for example, a serum free light chain, they would be eligible, as long as there is something that we can measure.
Mhm. Okay. Okay, Gary, do you have other questions? I'd like to open it up for caller questions.
Yeah, open it up, please.
Okay, if you have a question for Dr. Borrello, you can call 347-637-2631, and we have a caller at 983-6757. So go ahead with your question.
Hi, Dr. Borrello. Thanks so much for taking my call. My name is Dana Holmes, and I'm a smoldering myeloma patient. So I'm trying my very best to follow along, and I thank you for being so detailed and descriptive, which has actually helped me to better understand all of this, even though it is very, very complicated. I have a question, though, for you based on an interview that Jenny did last week with Dr. Pavia. He indicated that there are myeloma cancer stem cells which contribute to myeloma relapse. But he also indicated that these cells have actually yet to be identified. Therefore, it's not yet known what, if anything, can target these cells. So theoretically, would your treatment target these cells that contribute to myeloma relapse?
Yeah, so that's a very, very good question. And so I can tell you that this whole question of cancer stem cells is another very hot topic right now in the fields of cancer research. And there's a colleague of mine here at Hopkins, Dr. Matsui, who has done work in sort of identifying a cancer stem cell for myeloma. And Dr. Paiva is right. I mean, we don't know for sure, but there have been some work, including the work done here, that has suggested that the myeloma stem cell is a CD138 negative cell. So plasma cells and myeloma cells normally express this protein CD138, but that the stem cell is CD138 negative, and actually is more like a B cell, which is the sort of the parent cell from which plasma cells derive. So we, in our first publication, we actually used his assay where he can basically take bone marrow and deplete it of mature plasma cells. And basically all he has are B cells there, and grow out ultimately myeloma cells that look exactly like the original myeloma cells, suggesting that this CD138 negative cell may in fact be capable of generating progenitors or offspring that are the plasma cells. So we used this assay, and we added activated mills. We added mills to this assay and showed that in the presence of these mills, we got about a 80% reduction in the outgrowth of myeloma, suggesting that the broad specificity that these cells cover, that these mills cover or recognize, may also include antigens or proteins that are present and that can target the myeloma stem cell. This is the extent of the knowledge that we have, but I think theoretically the fact that we're taking this from the bone marrow and that these stem cells also reside in the bone marrow is one thing that may be suggestive of the fact that they may have recognition also to the stem cells.
Thank you so much for explaining that.
You're welcome.
That gives really certainly a lot of hope to every myeloma patient that is likely listening into your interview today. I wish you the best of luck, and thank you again.
Thank you very much.
Okay, thank you so much for your question, and thank you. This sounds like a very broad approach as opposed to a highly targeted approach, and I think the highly targeted approaches are great, except that myeloma it seems like it's so complicated and so kind of wily in nature, where you knock it down in one place and it grows in another place. So I think
Absolutely.
it sounds very exciting to me that the approach could be more broad and very personalized. Okay, we have another caller, 204-6956. Go ahead with your question.
Hi, thank you for taking my call. I have a couple of questions. My first one is, if a patient is accepted into this trial, what do they need to travel? What is their actual time commitment to participate over the long haul?
Yeah. So it's a transplant. So basically, you do need to travel. You need to go to one of the sites that are open. Well, so we're the only site that are currently open, but hopefully these other two that I mentioned in Florida will be opening within the next few months. So you would need to come here to be seen initially, to be screened for eligibility. Then you would need to come back to get the bone marrow harvested, and then you would need to be here for the transplant, which was roughly about I would say about 3 to 4 weeks of staying here in Baltimore, which might not be the right place to be right now, but it's getting better. Or one of the other sites.
Okay, and if a patient is having economical problems, is there some kind of assistance for travel?
No, there isn't, unfortunately. No, I'm sorry about that. Yeah.
By the way, I love Baltimore, so I'm sure it will be fine to travel there shortly.
It's a wonderful city.
It is. I love it. Okay, so do you think that this kind of treatment can eventually, for example, if you add bortezomib or dex, do you think that adding those additional medications might improve the outcomes?
Yeah, that's also a very good question. So I would argue no, and I'll explain why. So in fact, what I didn't mention is that in our current trial, we're giving patients lenalidomide starting at 2 months afterwards for two reasons. One is that it's got anti-myeloma properties, and there's clearly a lot of data to show how, given as maintenance therapy, improves outcomes of patients with undergoing an autologous stem cell transplant. But the second reason, and potentially the more important one, is that it's also immunomodulatory. It can augment T cell function and maintain T cell function. And so we're hoping that by the addition of that, we can basically maintain or expand the lifespan of these mills. In contrast, bortezomib and steroids actually kill lymphocytes. And so, if you're trying to come in with a therapy that is trying to elicit an immune response, you wouldn't want to give drugs that would then blunt it dramatically. And so we are not allowing for those two drugs to be used after the mills are infused. Now, before the mills, patients can get whatever they want, but once they get these mills, then they're not allowed to use either steroids or proteasome inhibitors such as bortezomib or carfilzomib.
Okay. One last question. How quickly can you start recruiting patients and
So we're recruiting. We're actively recruiting patients. Yep.
Oh, okay. Sorry, I missed that. Thank you.
No, that's okay. Yep.
Thank you very much.
You're welcome.
Okay, that was an additional question that I had. I actually have two more questions. So the induction would be just standard induction therapy that you traditionally use for a transplant, right?
Yeah, it's dealer's choice, whatever the patient is on.
Oh, okay. And then could you include post-transplant any other, ultimately, maybe not in this trial, but ultimately another kind of immunotherapy, like a daratumumab or something else?
Yeah, absolutely. As you said, in this trial, we're currently not including it, but we certainly could envision something like that. Absolutely. Okay.
Well, could you give us an idea, and I've asked this question of everyone that's been participating in this MCRI series, just an idea of your timeline, the different milestones, and then the budget requirements that you would be looking for or that you would need to make this happen?
So you're talking about in terms of the proposal?
Uh-huh.
Yeah, so the proposal that we're looking at is really taking advantage of the samples that we're getting from this clinical trial to really try to understand what are the specific antigens that are being identified and how we can basically make a better mill moving forward. And so in a way, it's really focused on translational work coming from the clinic back to the lab. the timeline for doing this, the advantage that we have is that we already are more than a third into the trial, and so we already have samples that we could be working with. And I think that we could begin to develop and to obtain some reasonable data, as early as a few months from now, based on some of the things that have been proposed, but more definitive data in terms of making CARs, which is one of the things that I would like to do, to make CARs that are specifically targeting high-risk myeloma patients, but using MILs as the source of the T cells. That would probably be something that would take as long as 2 to 3 years, from initiation of the trial, of the work.
Okay. And how much would you, some of these, sometimes it costs thousands and millions of dollars to do the studies, and sometimes it takes $1,000 per patient. What do you have any thoughts about how much would be required to continue that aspect of your research?
Yeah, you know what? I don't right now. I'm sorry. I have to actually. I just don't want to throw out a number because
right.
I need to think about this a little bit more. So I don't have a clear figure in my head right now.
Okay. Well, Dr. Borrello, this interview has been extremely enlightening. We are so thankful that you're working on this. We're thankful that you are looking for this broad approach to help not only high-risk patients, but relapsed refractory patients, and ultimately all patients.
Well, thank you very much, and thank you for the opportunity to allow me to explain all of this to you and to your audience.
Oh, well, it's so helpful to know the details and what you're trying to accomplish, and we're cheering you on. We're very excited for you.
Yeah,
thank you very much.
One point that I might get a little clarification from. At the very end of what you just said, Doctor, you said that you want to develop CAR T cells that use the MILs as the target, or as the T cell?
No, MILs as a T cell source.
As the source. So, but what, is it going to have a CS1, or what's the target? What is the target on the?
So the target. So that's exactly where I think this proposal differs from, what's currently being developed, and that is that. What I'm saying is that I don't know what the target is. I would like to find it based on the work that we would do from the samples obtained in this clinical trial, and to come up with potentially a novel target. CS1, BCMA, 19, CD38. These are all currently being used and being developed, and potentially going to be very promising. But none of these are specifically targeting high-risk myeloma intrinsically, because these are just antigens. These are just proteins that are expressed everywhere. What I'm hoping to find is something that's new, that we can specifically say for high-risk disease, which I think we all recognize currently as an unmet need. This specific antigen or this specific CAR may make a unique impact.
So you're suggesting that there's something on these MILs that would be a target that's going to be the home run for high-risk multiple myeloma.
Well, I'm not going to say it's a home run, but I certainly would hope that it would make a major impact. It would be nice, but I don't think so.
Well,
right.
you're providing a far smaller universe of T cells, ones that are highly activated for that cancer. So it seems like it's if there is something on the surface that you can activate these CAR cells with, then it looks like that would have a big impact if it exists. We just
yes, absolutely. No, but
yet.
It does exist. We just have to find it. It definitely exists. These are different. This is a different disease, so it exists.
Okay.
Right, and so then at that point you could segment, once you have your data back, you could probably segment the difference between maybe a deletion 17 patient and what target they might have versus a 414 patient and what target they might have. They might be totally separate.
Absolutely.
Okay,
very,
great.
Very interesting, Doctor. Thank you so much.
Well, thank you.
Yes, thank you so much for participating in the show. We are very, very grateful for your work and all you're doing.
Thank you very much. I appreciate it.
Thank you for listening to Myeloma Crowd Radio and the new MCRI series. Patients can help support the discovery of a cure, and we encourage you to become more involved.
Hello, it is Ryan, and we could all use an extra bright spot in our day, couldn't we? Just to make up for things like sitting in traffic, doing the dishes, counting your steps, you know, all the mundane stuff. That is why I'm such a big fan of Chumba Casino. Chumba Casino has all your favorite social casino-style games that you can play for free anytime, anywhere with daily bonuses. That should brighten your day a little. Actually, a lot. So sign up now at ChumbaCasino.com. That's ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.